Hello and welcome to MedCity's Pivot Podcast. I'm your host, Arundhati Parmar, Editor-in-Chief of MedCity News. Now, prior authorization has been a major point of contention between providers and payers. Patients also show up at the pharmacy only to be told that their insurance hasn't approved the drugs that their provider has prescribed. All of this causes untold frustration. Now, as a result, many efforts are being made to modernize prior authorization to make it less burdensome. Today, we will hear from two experts in the field about how prior authorization is being modified and how it will impact patients. Our guests are Javier Gonzalez, President of PBM and Commercial Strategy at Abarca Health, which is a tech-enabled pharmacy benefits manager, and Tanvi Patel, Vice President and General Manager at Amazon Pharmacy. Today's episode is sponsored by Abarca. So, Javi, I'll start with you. From a payer perspective, what does modernizing prior authorization really mean? I mean, is it simply making it electronic? And what are some of the challenges to doing this at scale?
Yeah. I mean, for me, at least from a health plan perspective, when we talk about modernizing the prior authorization experience at scale, for me, it's multi-pronged, right? I think that there's an opportunity around. So the three things I think, and then I'll expand on. Number one is I think there's policy complexity. Two, I think there's data quality that we need to think about. And then third thing is I think that we also have to talk about operational risk, right? And so when I think about policy complexity is, there is just not one clinical drug rule, right? There's thousands of prior authorization rules, maybe multiple thousands of prior authorization rules. And so you really have to think about, like, when we want to modernize at scale, like, obviously you got to build decision trees, right? So there's some work around that. But I think there needs to be a reevaluation of the complexity factor and which prior authorizations should maybe not be prior authorizations because they're low value prior authorizations. Two, when we think about the data quality, it's hard sometimes to get accurate real-time information on the entire patient, right? There's information asymmetry. So the health plan can be well-intended, but if you don't have the right EHR connections, you don't have the right EPAs or real-time benefit transactions, it's difficult to be successful without having full information. And then the third piece is the operational risk. And I think that when you go at scale, especially with large health plans, I think you have to be careful about going too fast and removing all the barriers, because you could end up approving drugs that are really not appropriate, right? And you can increase the expense. Two, on the other side is if we don't do things well enough, then we're not providing that right level of guided care and clinical algorithms so it's the balance, right? There's pros and cons to moving quickly. So I'll leave it at that.
And that makes sense. I mean, I will talk from a personal perspective, and this was a medical prior auth, not a drug prior auth scenario where I had an older brother who was diagnosed with stage 4 cancer, and his doctor wanted radiation to be done, and it took 7 days for the prior auth to come through. And he's a stage 4 cancer patient, and you're like, okay, this is just spreading while we're waiting. So it's emotionally stressful, and I cannot imagine what it must be for patients. And Tanvi, you can weigh in on this, when they go to the pharmacy and see that they cannot pick up medication that they think they need. So where does trust break down? What does the current PA experience feel like for patients?
Yeah, and you just kind of nailed it, right? And I think that all of us have an example that we can dive into to say, why didn't it make sense? From a patient's perspective, prior authorization doesn't show up as a safeguard. That's why it was initially introduced, as we're hearing, and that's what we talk about. But it shows up as a gap. To your point, imagine a patient that's just been diagnosed with type 2 diabetes, and she leaves her office thinking, okay, I'm going to start treatment. This is the start. And then there's just nothing. There's radio silence, and no one explains why there was a pause. It's excitement, and then there's a pause. And it's not that feeling that something is happening, because something may be happening. She's just not a part of it. It's her
Right.
care and she's not a part of that journey. That's what it feels like from the consumer standpoint. So she starts asking the basic questions. Did my prescriber miss a step? Is my plan doing something on my behalf? Is the pharmacy missing something? Do I need to call someone? What's happening? And that's where the patient loses trust in the system. And that's what it feels like for consumers. And most of the time, she's not getting any clear answers from anyone, not knowing where to call. And that's where the trust breaks down. So the system feels fragmented when really, as we were hearing, it needs to be interoperable. It needs to feel coordinated on her behalf, and it doesn't. And that's what we're starting to piece together here. And it starts to feel like the system is not working on behalf of patients.
So, Tanvi, I'm going to stay with you. Medication adherence is a big issue, and has been for quite some time. Not just starting the medication, but sticking with the therapy. And so, when I think about Amazon as a digital pharmacy, I mean, what is your role in supporting, and managing the prior auth experience all the way from the initial communication to the fulfillment of the drug being delivered?
Right. So once again, adherence doesn't start with the first dose. It starts when the prescription is written. All of those elements that I was just mentioning, where trust has been eroded because of silence or, a misunderstanding of what's happening, you're already starting to not trust the system. You already don't want to take the medications. You've already lost a little bit of hope. And so we need to build that trust, because that trust means that you're going to trust the system and trust the treatment. And that's where adherence first starts. So that window between getting the prescription and having that medication filled is where a lot of the process on medication adherence and health outcomes can go wrong. If the patient is waiting and they don't understand why, confidence is out the door. And that's when actually the stats show it, 20 to 30% of the prescription taking, drop off happens at that point. It's because of the prior authorization failing. The patient needs to have that transparency. So that's where Amazon Pharmacy is trying to solve that transparency question. We can work with partners like Abarca to know what's happening and ensure that that patient that has now opted for a digital pharmacy experience has transparency to what's happening. Patients have visibility into everything else in the world today, right? When their pizza is going to be delivered, down to where their shipments are and everything else. So why not also every step that's happening behind the scenes on their behalf, frankly, for their care? And at the end of the day, we lose them even before it starts. And that's the problem today.
Yeah, I mean, you talk about you being able to track pizza delivery, certainly when your Uber is arriving or anything like that. I mean, in healthcare, we're still dealing with faxes and paperwork. I don't know if you guys know or not, but recently there was an announcement from CMS that in 2 years' time, they're going to be getting rid of all faxes.
Exciting.
And I know, 2028, hallelujah. So Avi, the question for you is, when it comes to prior auth, what benefits comes with establishing electronic workflows?
I'm going to answer that question, but I want to go back to the comment you made. First of all, it's super exciting that CMS is, we've had a chance to meet Chris Klump. And it's certainly really dynamic, amazing gentleman, and really smart. And I think he really wants to move the needle in terms of facilitating a good environment for modernizing the delivery of healthcare, which I think is really refreshing. But that particular rule right now, from what I understand, is specific to like medical, like X-ray exams and certain types of things. It's not really related to the pharmacy piece yet. Having said that, though, I further expect that we're going to see more regulations expanding that net, right? So that hopefully one day we can move past the quote unquote 8-track tape and move, of the world to move to something more modern. But like the impact for me, when we think about making things electronic and what we can expect is, look, electronic prior authorizations, EPAs, are a good first step, right? Like I think that they've begun to make an impact. I think that, I've seen studies that show that they can save 60 to 70% of the time and effort associated with that. And when you're thinking about these physicians who are paying $20, $30 in administrative costs to administer these prior authorizations, and I'm sure Tanvi in her operation, she probably knows that line item as well. It's certainly refreshing, right, to be able to have that. And I think we'll further, especially with EPA, I think that we're going to further see regulations helping. We have this rule H057, which is basically more on the medical side today, with medical procedures mandating FHIR APIs, and that health plans are going to have to be able to support that. Intentionally, they've excluded the pharmacy drugs from that today, citing that there's different standards and ways to work on that. But I think that we'll probably see an expansion of that, because until we make it mandatory, like we need regulatory, unfortunately, we've not been good as an industry of like rallying around and getting standardizations and frameworks. So I think regulation will continue to be the main driver, and it won't be optional much longer. It'll be mandatory, and I think if we can do that and we can begin to standardize that experience throughout the space and stakeholders, I think we'll all be better for it.
So you talked about standardization. If you were designing prior authorization today from scratch, where would you hit the delete button? What would we not build moving forward?
Yeah, I think that not having a standardized interoperability framework from the get-go could have been a lost opportunity. I mentioned earlier low value drugs, right? It just doesn't make sense. I think when you're approving 95% of the prior authorizations, you really need to think about the costs associated with that. And then the third thing is, we need to figure out how to use the information and move from information asymmetry to information connectivity in a way that we can clinically intelligently approve prior authorization drugs even before they even have to happen, right? So those are some of the things that if we were to kind of have the chance to redo things, I think those would be things that I think I would think about.
That makes sense. Tanvi, you talked about the erosion of trust from a patient side, but there is a lot of congressional scrutiny that's coming on to pharmacy benefit managers, and it's because of that lack of transparency. And you have obviously Congress on one side, and then you have people with really large megaphones like Mark Cuban, railing against this lack of transparency. And he has urged employers to scrutinize their contracts and ask more from their PBMs and ask more questions about drug pricing. You work with employers as well. Amazon Pharmacy does. Do you think they need to do more for their employees when it comes to drug pricing?
It's a question of not necessarily doing more, but inspecting more closely, right? Potentially employers, plan sponsors, they are out there finding an experience or a benefit, and they're designing a benefit on behalf of their employees. But this has usually been delegated to those third-party PBMs, to your point, because it's been so complicated. And when it's delegated to an outside party, that distance between what the design and the intention of the plan design was and the real world experience for their employees can vary. So employees start to feel that very quickly when they need that care. And that's where employers and plan sponsors can step in to say, don't just think about the contract, think about what the intent, the spirit of your benefit was, and ensure that that is the actual lived experience for your employees. Understand where the friction is showing up. Do the employees actually know what's happening? Because then you make it more transparent as an employer, what you've built as a benefit on behalf of your employees, and you can react to that very quickly. It's really kind of comes down to what Amazon always says, and being customer obsessed. For an employer, their customer is their employee, especially for the benefit design team. And they should be thinking about, did I build the right benefit design on behalf of my employees? Where are they not getting the care that they need to trust me as their plan sponsors? And if I outsourced this decision to someone else, did they actually build a benefit design that was what I intended to do? Because at the end of the day, the benefit only works if the employee can actually use it. And that's the part that matters most.
So let me ask you a broader question. So a few years ago, MedCity News reported on how Blue Shield of California, took a look at their entire PBM structure and decided that we're going to step away from the legacy PBM solely and basically work with different entities. Amazon Pharmacy was one of them, and obviously Abarca was one of them too. So that was sort of a notable moment, but I'm wondering whether you think that sort of feeling is percolating within other companies too, where they're taking a closer look, as you said, inspecting more closely some of their entrenched relationships?
Yeah, I'm happy to kick that off. And Javier, you might have some thoughts on this as well. But I think that the Blue Shield of California example is just one very visible example a couple of years ago. They kind of started the momentum on this potentially, but we're seeing so many more plans, plan sponsors, employers explore these modular approaches. It's going to take some time, because at the end of the day, to move from a fully vertically integrated PBM all included model, like I was saying that, the historical model was, to move to something more modular, there's an operational burden that plan is taking on, that employer is taking on, and that takes time to shift some of those approaches. But another good example of that is what we just started with Emblem Health in New York this year. So Emblem Health moved away from a big three, decided what their members wanted, chose a non-vertically integrated PBM, and became their mail order pharmacy for all of their 3 to 4 million lives in the Northeast. So you're seeing a lot more plans pick up the phone and call and say, we'd like to understand what you're doing in these modular models and understand if it works for us. But sometimes these contracts are very long and it just takes time. But at the end of the day, I do think that these plans are looking for simpler benefit designs that are better fit for their members. And that's where we are, happy to have that conversation to say, how can we fit in and work with you more directly? The fewer points of service layers there are between a patient and where that patient gets care, the better it is for outcomes.
And I know Tanvi mentioned that it's a big lift. It's not easy to, when you've done something for so long in a certain way, to sort of reviewing it. But isn't cost savings a big part of that discussion?
Before I go there, I want to just springboard off what Tanvi was saying. I think your question, I think organizations like Blue Shield, in our experience, right? Because I think that when you think about what you just talked about in terms of the transformation in the business model that Blue Shield brought to market, we're considered pioneers of that, right? We were the founding companies of that strategy. What I would tell you is, at the core, I think companies like Blue Shield are, when you get down to the why, deep in the essence, it's based on trust and transparency.
Mm-hmm.
Okay? And I think that a lot of these organizations that are working with status quo PBMs that are maybe more vertically integrated, I think there's challenges around access to data, visibility of data, value. There's opacity, and there's inflexibility sometimes. And I think that it remains to be seen how it evolves. But in order for this to be successful, it really rallies around and centered on, you have to have a modern platform, right? A technology platform that can be highly interoperable, and not only from a technology perspective, from a business practice perspective, and be truly willing to partner with the best of the best. And I think that's unlocking doors. I don't know if all the health plans will go as complex as our partners at Blue Shield did. I certainly think that they've done some incredible things, and I think that they've set the bar for the market. Cost savings is obviously very important, right? I think all these big health plans are struggling, right, with all the financial headwinds, pressures. PBM reform is also health plan reform,
Right.
because they also manage, Medicare lines of businesses and commercial. So, the solution also has to allow for flexibility and strategic agility to manage the cost of goods, right?
Makes sense.
So I don't think they're distinct. I think that they're all kind of factors that have to be involved or evaluated as these plans move forward.
So, even as insurance companies are taking at modernizing, prior authorization, other startups, tech-enabled startups, are not sitting back. I've seen so many companies that began, say, in ambient AI, now say, we're going to create such a perfect physician note that you hospital and you dear provider don't have to worry about clinical documentation improvement teams, all of these will be taken care of during the physician encounter and as soon as it finishes. So eh, I'm curious, what is your take on this, Javi? Is it a good thing that multiple heads are looking at this prior authorization problem, or is it just people with technology thinking that they can just snap their fingers and the problem will be solved?
No, it's a great question. I mean, we just had our forward, you know, think thought leadership meeting, and we centered the entire conversation. We were about how do we modernize healthcare together, and the central theme topic was based on modernizing a prior authorization experience, and we had all the companies there, whether we're SureScript, CurMyMeds, Doctor First, TriZetto, Latent, Arrive Health, right? And these are all organizations that play a very important role in modernizing these experiences. And so I think that for me, I think there's a lot of opportunity in what you just said. And I also think that, when prior authorizations came out, it came out in, like, let's call it the utilization era of time. And if prior authorizations would come out today in more of a value-based era, where I think we're all heading to, total cost of care, how would it look? Would it look different? And I think that one of the missing pieces as we continue to transform the prior authorization experience is, I don't think we have aligned incentives. We have a health plan controlling the utilization, and then the burden is distributed along providers like physicians, pharmacies, and members, right? Mm-hmm. And no one is being incentivized to reduce the burden.
Right.
So I think that if I were to close my eyes and snap my fingers, if we could hold health plans accountable to time to therapy, right? So that there's actually metrics, and maybe one day and down the road it's a star measure, right?
Right.
So that when I'm a member and I'm trying to make a decision on a health plan, that time to therapy is something I can look at. Okay. Mm-hmm. Two, if we can incentivize prescribers for making the right decisions, whether that is to approve the prior authorization or decide to choose a different therapy. That's why it's so important to have real-time benefit transactions and EPAs. That would be good. If we can incentivize pharmacies like Tanby, like Amazon, and to reduce pharmacy abandonment, medication abandonment, right? Mm-hmm. Adherence rates, that would be a good day for us, right? And so those are some of the things I think about, where if we can get some alignment across all stakeholders and rethink about how we deploy prior authorization strategies in the future, I think we'll be pretty excited to see the outcomes of that.
So let us look at the future. Tanvi, let me come to you. If we look 5 years ahead through the eyes of the patient, how will, consumer expectations, and hopefully we'll have more transparency then, how will that redefine what is acceptable in terms of the timelines for prior authorizations? Do you think that those rapidly changing expectations will force the system to evolve?
Absolutely. I mean, and I have hope that it's less than 5 years from now, because I think what we're seeing right now is that consumer expectations are really starting to reset what's acceptable in prior authorization. Whether policy does it or not, this is the consumerization of healthcare, and that's what's going to reset those expectations. Patients, as we were talking about, already track everything else in real time. So having a multi-day black box for medication access, it's unacceptable. That silence is starting to seem like failure, and that no update will feel worse than a denial, because at least a denial is actionable, right? So, in the future, and hopefully a few years from now, if not 5, timelines are not going to be defined by what the system can tolerate, the faxes and the prior approvals there, but by what consumers are expecting, and things like same-day delivery or transparent pricing. It becomes the norm. That's the bar that will keep rising. And as Javier was saying, there's a lot of opacity in the system today, but that's not just frustrating. It's actually eroding trust.
So, Javi, I'll close with you. Then we talked about, rapidly evolving consumer expectations. So the cultural change we're already seeing. But what is the other single change, be it policy or technical, that you think would most improve prior authorization for patients?
I'll say making prior authorization workflows invisible to
Okay.
the prescriber, and to the patient, right? So that it is very, very straightforward and easy. There's no friction, there's no opacity, making it very transparent. Everyone knows what's going on, eyes wide open. I think that's one thing. I think the second thing I think about is, as I mentioned, is really getting this framework of interoperability and standardizations, whether it be the NCPDP script standard or the FHIR standard, ubiquitous across all stakeholders, so that we can all try to standardize that experience. And it's not different in Oklahoma than it is in New York, for example, right? A patient shouldn't be held liable for that. So those are some thoughts that I have.
On that hopeful note, thank you so much, both Tanvi and Javi, for conducting this fascinating discussion on prior authorization.
Thank you.
And my pleasure.